Hello, everybody. Thanks for coming tonight for our webinar. I'm Eric Nunley. I'm going to be presenting tonight on implant placement and case planning. What we're going to be doing is looking at a comprehensive look into implant planning and placement, going over from basic fundamentals all the way through a little bit of minorly advanced things and a lot of parameters that can help the GP that's getting into implantology. A little bit about myself. I'm a general dentist. I graduated from the University of Louisville, 2013. Before that, I was a dental technologist. I graduated from dental laboratory program in 1999 before going back to dental school, and always knew that I wanted to be heavily involved in implants. I knew that implants were the future of dentistry. Began placing implants in my practice, which is a general practice in Louisville, Kentucky, in 2015. Since then, I became more and more involved. I went on to more and more training, looked for more advancements in my certifications, and became a diplomate for the ABOI in 2021 and a fellow of the AAID in 2022. But even though I do run a general practice, I do a decent amount of implants, but general dentistry is still the vast majority of what I do on a daily basis. And if you're wondering about the pictures down here in the lower right, the only other thing I do is specialty-wise outside of implants is I am the dentist for the University of Louisville athletic department, so I get to see all the student athletes, and I really love being involved in sports dentistry. Okay. So to get started with, I'm not sure the skill level of everybody is logged in right now, and I appreciate everybody who's here tonight. And thank you for Biotech for asking me to come and do this webinar tonight. I'm going to start out with just some implantology fundamentals for people that are of, more of a beginner or entry level. So when I started in 2015 or 14, when I was wondering if I should get into implants, I had a lot of questions because at that point it was a heavily specialized, procedure. It was mainly send somebody to a periodontist, oral surgeon. Not a whole ton of GPs were doing implants, but I wanted to know, should I be getting trained in implantology? And I think that the GP community definitely should be getting heavily trained in implantology, mainly because a lot of us have not gotten that training in dental school or after school. And it is becoming more and more of a GP related procedure. So let me see, go back. Oh, sorry. So like I was saying, implantology is largely fallen into the laps of the GP community, a lot like endodontics and some things have. We need to be knowledgeable of implantology. We need to have it as one of our first arsenals in our treatment planning and be competent in the implantology to where even if we do decide to only do a few cases, or even if we decide to only pass those cases on to a referral, to be knowledgeable about implantology in general, what's possible, what is ideal, looking at screening patients in advance, looking at what the outcome is going to be. Because when it comes to implants, the outcome is everything. And if we can properly diagnose our patients from the front end, even if we're referring, or hopefully we are actually placing most of those implants ourselves, which it really is what it should be, that we know how to treatment plan, present that, and then carry out quality implant surgery in our practice, which I think is very, very possible for the vast majority of general practitioners. However, it is different. It's something that we have not been trained in. Or some have not. But I graduated 2013. I had almost almost zero implant training when I was in dental school. So as I got out, I realized I had to get trained. I had to get knowledge about this specialty. And in the end, like I said, even if you restore out, you have to be able to restore the cases. You have to know if who you're referring to is good. And it's basically the knowledge of implantology that we have to learn as GPs. So if you're a GP that's looking to start doing implant in your practice, it is a unique offering that does require a lot of good knowledge in most of the different related specialties. You have to be a good surgeon. You have to be able to analyze the patients on the front end, diagnose what their needs are, get realistic expectations for what's going to be the desired outcome. So your patient is on board, because a lot of these cases are quite expensive. We need to look at them medically, look at the radiographs, assess what we think we can do. Then when it comes to the actual surgery, being good surgeons, soft tissue work, planning for the restorative procedure, which is always what matters in the end. And most importantly, which I've always said, is that as a GP, identifying and managing complications is probably the hardest, but the most important thing that we need to be able to do. Is we need to be able to look at something and say, this looks good or does not, and be able to look at, say, this is not heading the right way. We need to intervene. That's for any GP, because implants are going to be in your practice all day, every day, more and more and more every single year. And also need to understand that implants, although they've replaced teeth, it does not mean that they follow the rules that we've learned that teeth follow. Things like crown height, root to crown ratio, Ante's law. A lot of these things, they don't translate to implants. They follow their own set of rules. And even though they are replacing teeth, sorry, they don't follow the rules of teeth. So to understand that from the beginning, we have to realize that dental implants they're not teeth in the regards that they have a periodontal ligament, they have some cushion, they have some movement. Dental implants are osseointegrated into the bone, and they are completely rock solid. They don't have any compression upon bite. The periodontal situation around the tooth is very different. They don't have, if you can see on my screen, if you look to the left side, I like these pictures because it shows you that the fiber attachment to the roof surface, that's real attachment. So you don't get pocketing if you have that attachment on a natural tooth. On an implant, you're going to have pocketing even if the gums come around the crown to a higher level, because they don't have that real attachment. At most, they have a hemidesmosonal, almost like a suction cup type attachment to the crown. And if you probe around them hard, they're probably going to bleed and the tissue's going to push away. So they don't act like normal teeth. So again, I'm not sure how much everybody knows about dental implants, so we're just going to start right from the basis of the implant in general. An implant is a replacement for a tooth root, and it goes into the bone. The bone heals around it, and what we do on top of it can have various options. So a typical implant, and even though we're talking about biotech tonight, I'm going to use a lot of different examples. I do use biotech. I think it's a great implant. Every implant company has its own specific design, not completely specific, but a lot of the implants you'll see have a lot of different designs. So what I can tell you is that at the crestal portion of the implant, often you'll find micro threading. You'll see these small, thin threads right at the crestal portion. Those are meant to maintain bone loss and to prevent crestal bone loss at the top of the implant, which is typically the most common problem with implants in the long term is, are you maintaining your bone? Every implant's going to have a different type of, or there are various types of surface treatments. The titanium itself is going to either be acid etched, sandblasted, or some companies may have, claim to have a proprietary treatment that they use for their particular implant. Then there's going to be the internal connection. That is where your restoration or your hybrid denture attachments, anything meets the implant. And there are different connections for that, different internal connections, different timings. Everybody has their different system. And then there are different thread designs. There are all kinds of research. Everybody, has their different theories about which thread design is better. Okay, so what I want to start with here is just outside of that basic anatomy. The basic anatomy is that there's an implant with threading and different various treatments to get it to osseointegrate. Now, when you go to the top of the implant, you get to how is your connection and what is the preferred connection for doing your restorations. What I want to do is just look back at this is a little bit of history. It's not so much history because a lot of people still have these connections. Initially, we saw a lot of flat on flat connections like you see on the left side of the screen, to where the components meet the implant on a flat to flat connection with an internal retention portion. Largely, they have moved a little bit more towards what's called a conical connection, which is you see on the right side of the left side of the screen, where the connection is built more into the internal of the implant and the screw chamber is a little bit lower and it forms a little bit more of a seal. A lot of people over the years have said that, it's a little bit up in the air, but they blamed a lot of the crestal bone loss on flat connections early on, and micro wicking and a lot of things that we won't get into tonight. But largely, the conical connection has become the new standard for implant connections, meaning we've pulled the connection inside to where the abutment screws down more internal into the diameter of the implant, which prevents micro wicking. It forms almost more of a cold weld type of a seal. You put these abutments in, you screw them in, the connection is really low, and they are rock solid. Most of the time, you have a harder time removing them than you do of anything else because they really lock into the implant. And the lateral movements, they don't have the micro wicking of, bacteria that a lot of people have attributed to bone loss at the crestal area. And they are showing to be superior in my opinion. So I don't use any implant that does not have a conical connection. So I want to look at these three different types of implants. These are, I've largely divided implants into little subcategories. You have your implant that you see on the left, where the threads are less aggressive. They do have some threading, but in the middle, you have the more aggressively threaded that are meant to engage more bone and get more primary stability. Those are the two types of bone level implants. And then on the right, you'll see is a tissue level implant where the abutment actually goes above the gum and you restore the case from a supragingival level rather than worried about healing abutments and that sort of thing. I use both on the left side. I don't use any tissue level myself, but I do use both the aggressively threaded and the minorly less threaded bone level implants. And we'll talk later about how we, gauge which one we're going to use on each of those. So the whole point we were getting to is, as we're talking about case planning, we're going to talk about implant placement and planning the cases. So I want to just go a little bit into why implants in general as a treatment option are I necessary in treatment planning and case planning, because I believe they're much less aggressive to adjacent teeth when you talk about prepping for bridges. They are great for failed root canals. They have the longest longevity of anything that we can legally tell our patients. They do preserve bone. Congenitally missing teeth are is a really good solution for people that have congenitally missing teeth, particularly 710. And it can take people that are in ill-fitting dentures that are just miserable, that can't go on anymore with their current situation. And we can give them a real upgrade to give them something that is a life-changing situation that makes their actual health and lifestyle better. We talk about Kennedy class 2 distal extensions. We don't have really any good crown and bridge options for those people. And when it comes to full mouth restorations, we can pick and choose where implants are good, where they might not be as ideal. It gives us way more options than we used to have. So when we talk about, let's talk about the difference between bridges and implants. I do very, very little bridges anymore. And I look back at when I first started before doing implants, how many bridges I used to do versus how many I do now. It is extremely low of what I used to do. And it's because patients are more aware. They tell me all the time, I don't want to bridge. I don't want to bridge. And it's a better outcome. And for bridges still do have a place in my practice, but they have become more of a secondary option in particular circumstances than the front line, which it was when I graduated in 2013. The cleansability, like we all know, of these bridges are low. And if you look to the case on the right, I put this up because this was a good example of a case that I converted a 4-unit bridge into a 4 single unit case with 2 implants between 2 standard crowns. You can see on the patient's left side, they have that other bridge still there. And if I look at these 2 options left to right, the one on the left, the implant option, is just so clearly the best in my opinion that we really don't do as many of these bridges anymore. Now, when it comes to failed root canal teeth, if you're a GP and you run a general practice where you're seeing hygiene patients every day, you're running general dentistry, but you also offer implants, you're going to find that failed root canal teeth are probably going to be your number one conversion of a hygiene patient or an emergency patient into your surgery. People that have had missing teeth for a long time are a little bit harder to convince to get an implant because they almost have become used to it. And healed site implants are a little bit harder than immediates when it comes to patient acceptance. So in my opinion, or my experience, I should say, when I have a patient that has a molar with a root canal and it breaks off at the gum line, those are the patients that they sign on for implants, and we end up doing immediate implants on those cases. Recurrent abscesses, root fractures, they happen. Anything that makes a root canal fail, it's almost always a good option unless you lose a lot of buccal plate, which we'll talk about later. So this is a standard case in my practice. This is a system that I have used for molar replacements. There's also other options, but this is just a classic example of taking a broken down root canal tooth and giving the person a great solution without prepping natural teeth that don't need it. Another thing to consider is bone preservation. We see people that are edentulous, at least partially edentulous, that are going to lose bone over years to come. Now, with implants actually preserve bone. And if an implant is properly loaded, it will promote bone growth and maintenance. And so instead of getting that saddling that you see where multiple missing teeth have been for a while, instead you'll actually see that bone being maintained. And it's even more more important when it comes to fully edentulous patients who you just know that if they're going to be in a conventional denture, I have some patients that go into conventional dentures in their early 40s or maybe 30s. You can just imagine what their bone's going to be like if they live to the age of 75. There's going to be almost nothing there left. And we've always seen those tiny little chin strap bone where people just become dental cripples at that point. Now, they must be properly loaded. Like I said, this is an important thing that I think everybody that's getting into implants needs to know, that overloading crowns is the number one cause of crestal bone loss. So even if you are deciding to refer out your implants, you're going to be responsible for maintaining the restoration. And if you have a patient that has a few implants, you need to know how to check that bite and make sure that it's okay. And I don't have a detail about this, but in general, if you have to realize what we talked about, that periodontal ligament not being there anymore. So when I bite right now and I squeeze all my teeth compressing that periodontal ligament, any tooth in my mouth that has an implant, that periodontal ligament does not exist. So if I lightly bite and I have a couple implant crowns and they all mark evenly with the other crowns, when I squeeze, everything else is going to compress, but those implant crowns will not, and they will be in traumatic occlusion. So you should have almost no contact on your crowns and a light bite. But when they squeeze into a heavy bite, that's when the crowns should look like they're in even harmony occlusally with the other teeth. You want those implant crowns to almost compress into occlusion, because if they do, they'll be properly loaded. If they don't, they will be overloaded, and your patient will never know because the implant will not tell them that it's being overloaded. They won't get pain. They won't notice it until they get 3-4 millimeters of bone loss, and then they're in trouble. And then on the other side, not loading the implants can be an issue as well. So if you do not load or promote that loading to tell the body that we need bone here, it will lose that bone and the bone will go away. And this is an example I had here that came to mind when I was getting this presentation ready. I saw this patient. She had enough money to get her implants at 8-9 years ago. She had them all placed. Then she ran into a situation where she could not afford to restore them, and she just left them. So these implants, I assume, were in good condition when they were placed. After that amount of time of no load, she lost almost all the bone around these implants, to the point to where they were non-restorable. You can say what you want about the placement. I have questions about that as well, but the non-loading of them meant that we had to pull all these implants out, and we had to develop the site and go back in and do new implants. And you can see that saddling that has occurred because of that bone loss. So again, I want to compare dentures to our other forms of treatment plans. Partial dentures, which I am not a fan of. I used to do them. I maybe have only done a few in the last 8-9 years, but they are very, very, very destructive appliances to our teeth. They're almost, I remember I used to hear them referred to as transitional appliances. They damage the teeth that they hold on to. Anything that's clasped has if you have a C-clasp around a tooth, there is a 35% chance that it's still going to be there in 10 years. There's a 60% that'll be there in 4 years. That's why we've all seen us do partials, and then we add teeth, and then it eventually becomes a denture. So I'll breeze over that. We all know that implants are superior to partial dentures, particularly when it comes to distal extensions. Now we get into complete dentures. There are two types of alternatives to the complete denture. There's an implant retained denture. There's an implant supported denture. It's something I think is largely misunderstood by a lot of general practitioners what the difference between those two things are. If you have a locator, you have a ball and an O-ring denture, you have anything that just clicks into place. It's not rigid. Those are only meant for vertical displacement of the denture so that when they laugh and smile and open their mouth wide, the denture doesn't pop up. Those implants do not support that denture. And if you develop a case where you are loading that denture, which I've seen many times, people put locators in, they relieve the bottom, and they don't get that support from the natural dentition. They overload those implants, and they're not meant to do that. So when you bite down, if you have an implant retained denture, locator denture, you should be biting down, squeezing, and all of that support should come from the buccal shelf or the hard palate, the natural support that a denture gets. If you're not, and instead you're squeezing down and that support comes from the actual locators in the denture, that is going to massively overload those, and those are going to be on limited time because they're going to fail. But when it comes to an implant supported prosthesis, a denture bar or a hybrid denture, actually support that basis because they're cross splinted. They are too much to get into today, but they're working as a team, and they are cross arch stabilized, and they can support and take that kind of masticatory function. Now, when it comes to we're talking about compared to a complete denture. Yeah, complete denture, we know that if you do implant actual supported, you can get 10 times the chewing force. You can get back to your actual chewing force. You can preserve the bone. You can give that patient back their options of eating what they want to eat. Like we all see on the commercials, I can eat what I want to eat now. So I think that's pretty clear. Implant supported dentures can be one of two options. And I think bar dentures are far underrated. I think bar dentures are fantastic. They are very, very strong. This is an example of a Dolder bar I did on a patient. We did this nice Dolder bar. This denture slips in and out, fully functional to a really high level. And the only problem I've seen with patients is they have this hang up on, do I have to take it out or is it in there forever? And even though I think bar dentures are better for a lot of people, patients get hung up on, they still have to take it in and out at night. They still have to take it out, clean it when they eat. So that's the hang up there on that. Then we get into implant hybrid dentures. And I know we're not talking about advanced stuff right now, but I'm just trying to lay out that as you get into implants, you can take this as far as you want to go. You can go singles, onesies, twosies, just these regular things, or you can go up into the full arch cases, which I think, honestly, I think are capable for the vast majority of general practitioners. It's just a matter of planning them, not getting outside of your comfort zone, doing guides when you need them, doing what you need to do to get these results. Because I did a lot of these cases early in my career, and they've been really good. And I'm seeing a lot more of patients like this. This is a great patient of mine. His name's Brad. I'm seeing a lot of recovering addicts, people that were really troubled, that lived a lot of hard years, that they're terminal in their dentition. This guy's 27 years old, and terminal dentition, been sober for like 4 years off of I think methamphetamines, ready to restore his case. So we were able to take him from his situation, place implants upper and lower, restore the case. This is another case of another guy. I think he was in his mid-30s, recovering from things, ready to get his life back in order. Put all these in. Now he's got upper and lower hybrids. It's a great option for people, particularly for the edentulous patients. I wouldn't necessarily start out with the full-blown, extractions and bone grafting, everything. But the edentulous, taking somebody from edentulosism to a hybrid it's so life-changing for the patient. It's really amazing. And those patients are, like I said, originally I didn't even know if I needed to do implant training because I used to refer so few out. I didn't even restore any hybrids. I had no patients that would even consider it. But as I got trained in implants and started doing them, the patient acceptance really came mainly because they had trust in me and I didn't send them out anywhere. I think was almost the biggest factor in that. Okay, so we're going to go into the basics of implant fundamentals here. This is your surgical kit. This is the biotech kit. I've used, God, probably 16, 18 systems over the last, since 2015. I'm going to show this kit here because I do think it's very streamlined. And I think when, as a GP, following these protocols of streamlining your procedures is very good. You have a surgical kit that you walk through, and really hard to kind of really illustrate that right now, but as you work with your rep or whatever implant system you decide to use, they'll walk you through your kit. It's almost like an algorithm. It's like, you go here, you go there. What's my width? Here we go there. And you move your way down. Just want to show this super fast. For people that are worried about going too deep, they're having issues. Drill depth gauge kits are actually really beneficial because, especially if you're properly diagnosing and what you're going to run into is you're going to have anatomy that's hard to deal with. And you only have 6 millimeters to work with. It's nice to have something that you can push onto the drill to where you're not going to go past that depth. And then there's the healing abutments, which go on top of the implant. Biotech has a good system for laying all that out, makes it real streamlined. Everybody has their system. So super quick, I don't want to assume that everybody knows the basic protocols of implant placement. The basic protocols, I won't spend too long on it, is you start your pilot drill where you think you need to be. You move your way up a sequential order of drills, getting larger and larger and larger. And at the end, you're at the right place with your osteotomy drill. You put your implant in at the depth that you feel is necessary. This is an example of the minorly threaded one. And then here's an example of the more aggressively threaded. The more aggressively threaded I use in softer bone. I use them in immediate placements. And sometimes they have a little extra step when it comes to a cortical drill. And there are not any real strict guidelines for where to place what implant. That was something I always wanted to know when I was first starting placing these is, well, what do I use? What's the minimum? Can I do this implant in this placement? That's a hard thing to kind of navigate from. And it does come down to getting the experience and putting the biggest implant you can in that place without compromising your restoration is almost the real rule. But like I said, everything starts with good imaging. I would shudder at any dentist that's placing implants without a 3D x-ray. It's been godsend for me. I would never go back from 3D x-rays. I think it's very, very much becoming the standard of care. Not only does it give you good imaging, it also shows you things that you would not have seen. This is an example of a case where we found there was a large abscess discovered when in the previous x-ray looked like everything was fine. You can see a lot of things in 3D x-rays that you would never have found otherwise. You can find things like small root fractures. You're going to have patients in the chair that are in pain. And the most frustrating thing for me as a dentist is having a patient in the chair in pain and I can't figure out what's wrong with that patient. That drives me nuts. And if I can take a scan, figure out what that problem is and diagnose it, it's amazing. So in general, as a GP doing implants, we should be able to take a cone beam, quickly analyze the case within minutes, maybe 1 minute or less. So this is a scan I took of a patient. We had grafted this case. You can probably see where the graft is versus where the natural bone is. This was a reevaluation. I took the scan, took some measurements, which are easy to do in most cone beam softwares. You can, analyze your width, your depth, your distance to your sinus, and you get a real quick picture to be able to look at the patient and say, here's what I can do for you. And in the end, you can put an implant in the correct place. This is a biotech contact implant. Analyzed it quickly. Didn't take long to figure out what we needed to do here. Put an implant directly to the sinus, biggest implant we could get with the most ideal plan for a restoration. And it really becomes that easy. So we're talking about surgical fundamentals. I know I'm getting a little bit long here, but the surgical fundamentals, if you're flapping, this is all I'll just say about this, make sure you learn how to lay a decent flap. I don't do as many flaps anymore. Any flapped cases, I'm largely kind of doing guided now, which we'll talk about later. However, incision lines deep down to reflect that periosteum is very, very important. 80% of the bone is supplied, their blood supply comes from the periosteum. So if you have a real jagged flap where you destroy the periosteum, it's going to be bad for the bone. But if you can lay a real clean, full thickness flap, you'll be amazed how well it heals. In general, when it comes to the osteotomy, copious irrigation, bodily movement of the handpiece, that just means you're not fulcruming, you're not arching. When you're doing your implant placement, you need to be doing a straight up and down placement. It takes just a little bit getting used to, and then it'll become very standard. And again, I'm going to get into a lot of, so as I was studying for the board for the ABOI, I memorized these parameters to death. They're great parameters. They're guidelines. If anybody wants any of these, I will send you all these parameters. You don't have to worry about this. But in general, the CEJ of the adjacent teeth, particularly in the anteriors, where you really want to make sure to place your implant, between 2 to 4 millimeters to the adjacent CEJ, and you want to be a little subcrestal. And if you're really planning, 4 to 5 millimeters restoration from the adjacent crestal contact point, that's for papilla. Because a lot of these cases, the papilla ends up being the hardest thing to manage, particularly in the anterior. And when you get somebody that spends that amount of money and they don't get papilla formation, they're not happy. So when it comes to posterior considerations, opening is an issue. Again, I can get all these things to people, but we're going to move on to basically placing them 2 millimeters subcrestal is more ideal. And when it comes to taking teeth out, I know you hear a lot about atraumatic extractions. Well, we call them minimally traumatic extractions. It's not rocket science. You try to take them out as easily as you can. Preserve the bone. Don't expand the socket. Don't cut into bone, because it's going to make your placement so much better. So like this case, take the tooth out. It almost looks like the tooth just disappeared. Section the tooth. Don't rock it back and forth and expand that socket like I was taught. Multi-rooted teeth, section them into their multiple roots, take those out. This is a case where we took the roots out, prepared it, put an implant in, got it right in with very minimal damage. So if you're evaluating the surgery site, when you come, particularly in the posterior, but also in the anterior, the buccal plate or the facial plate is always the most common issue. That's where we get our first bone loss on teeth that are going south. You can have a teeth with good bone everywhere, except it's got 4 millimeter dehiscence on the buccal. That always ends up becoming the issue. You have to evaluate the buccal plate. You have to try to be free from active infection, and you want to engage as much bone as you possibly can. And if you impinge on that buccal plate with your implant, it'll create more bone loss than you hope as well, which is why you want to lingualize your implants as much as possible. You want to push those to the lingual and graft or let natural bone form around the buccal side. Just like your typical case here. It's not super deep. Honestly, right now, looking at this case, knowing that I did this case, I would probably have put that implant a couple millimeters lower. Now, when it comes to guided versus freehand, that is, as I've trained people, and implantology. It's always a hot topic. When do we guide? When do we freehand? In my opinion, get very, very good at freehand and then do more guided. That's what I've done. I'm doing more guided than I ever have, but I used to do almost everything freehand. A lot of the cases that I do free-handed are based on different parameters other than it just being easy. However, I do have my little guide over doing guided cases. If it's a super slam dunk, however, and I know I can do it better guided, then yes, I'll do that. Or if there's a patient that is, I've had patients that can't even sit in a chair for more than 45 minutes. I'm going to guide those cases. And then there's cases where anatomy comes in, where you're squeezing a very narrow implant between two adjacent roots. You want to do all those guided, of course. And then when you're trying to avoid critical anatomy, you can guide or you can use drill stops like we talked about later. Other case that I think is very, very good for guides is when you have, let's say I'm doing 3 single unit implants side by side. I want to guide those so that we can precision put them where I'm going to get a good restoration, where I might put 3 good implants side by side, but 1 millimeter off 1-to-1 is going to create a bad restorative outcome. And then there's fully guided, which is where you put the implant through the guide. Partially guided is where you just do a pilot. I don't see many partially guideds anymore. So real quickly here, and again, we don't need to go over this in super, super detail because I know I'm getting a little bit long on the initial. The analyzing the patient from the beginning is important, but it's not something I think about as much as you would think. There's ASA's categories. You need to do implants on people ASA 2 and 1. 3 is not very often do I do 3. The major medical conditions that I worry about, number 1 is diabetes. And I'd say this because, not because of literature, I say this because my biggest nightmare cases have been diabetics. And no matter what we've done, they've run their blood work. The biggest nightmare cases that have just come back to be major cases to manage have been diabetes. That's because they don't heal. They don't heal well. So even if they are well controlled, they're ASA 3. And, or no, if, yes, well, type 1. Oh, so type, yeah, sorry. Type 1, like the best you're going to get is a type 3 or type 2 or a well-controlled type 2 diabetic. So it's always been, I don't worry about type 2 diabetes as much as type 1, but insulin-dependent diabetics really do scare me because you can do everything right and you can have some pretty big complications mid healing. Myocardial infarctions, and somebody has a heart attack, we just need to realize that they can't get any implants for about 6 months because then they're back to ASA2. So you just want to wait 6 months after MI. Periodontal patients, they have harder healing, but they don't worry me as much. Smokers are poor healers. These are people that, if you're going to choose to smoke, we have a disclaimer that says we cannot warranty the work. Vitamin D deficiency patients are kind of a new thing that's coming more and more about. A lot of people are vitamin D deficient, and it is shown to be as harmful than smoking and perio when it comes to this. The good thing about it is that you can put people on a regimen offered by Stella Life, which I use very regularly, which I stand by. It's to really heal these implants. And I've seen this product do some amazing things, which we won't get into tonight, but oral bisphosphonates are a medication of major concern. I can send anybody in here all these. I'll send these parameters. You could probably find them. You should do blood tests on people with that have been on bisphosphonates. They really have an issue if they have a CTX, which is just a blood work marker that you can do. Even as a GP, you can just say, I need the CTX report. And if it's not over 150, then I'm not going to do it. So as we get into anatomical considerations for implants, these are things that we deal with a lot. These are classifications of bone density. D2 being the number one best. That's what we want. We want a cortical plate with some spongy bone. We don't want super strong D1 bone. D3 is okay. D4 is very, very susceptible to failure. You'll see D4 in the maxilla is very spongy. So you can find these different bones in these particular area. The the anterior mandible is usually very dense between the two mental foramen. Now, when it comes to quantity and quality, I would challenge everybody in here to look at this picture on the right side and say, do you like that picture? Is that an implant you'd be excited to place? Because with me, without thinking about it and really, really looking at it, originally I look at that patient, I look at that cross section, I say, yes, I love that. Then this was that same patient that had the bone atrophy or the disuse atrophy. But if you look closer, that is D1 bone, and that is solid cortical bone, almost no medullary bone. That is some of the hardest bone to try to drill through. It's a nightmare. You have to prevent overheating. You have to just baby it to get anything open, and you may even have to go up a size in your osteotomy to get the lower size implant in place. And you can compare it here. Now that you see the upper bone, you can see that as the medullary bone up top looks a lot better than that lower jawbone. And that's just that it's like granite. So it's very, very hard to deal with. If you do get in the situations, you can have bone profile drills. Again, so we did get an implant in there, but I can tell you that's the only good one we got into that site. I'm not thrilled about that case because I could not drill that bone big enough to get the implant I wanted in. And I think we left at least one of them about a millimeter supercrestal, and I couldn't back it back out. So D1 bone is more the challenging bone, in my opinion. So let's get in real quick to the anatomy of the maxilla. This is the things that we need to worry about. There are sinuses, incisive canals, the greater palatine foramen. So go over these just real quick. Anterior maxilla, or the maxilla is a little bit easier to manage when it comes to vessels. The greater palatine foramen and the vessels that come out of that are the number one concern. We only say that because it's the only vessel in the maxilla that you can rupture that could lead to death. And it is scary, but it's actually very, very, very low in the palate. You have to reflect an extremely low flap in the palate to hit that artery. But a slip could, I've heard horror stories about, elevator slips that have lacerated that vessel and what happens afterwards. Other things about in the mandible, these things, the cone beams will show you these. There's a lot of things like the mental foramen, which you'll see on the right. The lower left, you'll see the incisive canal or submandibular canal. They're not of major concern. You can go into those areas without problem. You just have to be ready for a little bit of extra bleeding and that sort of thing. But we'll go over that. The mandible. The mandible is less concerned about, of course, not sinuses, but in vessels. It's mainly about one thing, in my opinion. We always are worried about the IAN nerve or the IAN. Now, that's because, it can lead to compression, can lead to paresthesia on the lower left lip, soft tissue, or lower either side lip, I should say. So as a general rule, just to point out, if you are going to do implants in this area, we try to numb the area without numbing the IAN. We don't give mandibular blocks. We don't give anything that numbs that nerve because we want that nerve to give us a warning if it's being impinged upon. You can get accessory nerves from nerves that used to branch off of that, but as long as you can take scans and know that you're safe, that's good. The other concern for me if I'm going to be just give people some signs of caution here, the fossa, submandibular fossa, you can look at a 2D X-ray. Like if you look at the right side, and if you can see that IAN nerve at the bottom of the scan, you look like you have a lot of room. But if you look at the left side, you realize that that IAN nerve is really low. However, that undercut on the interior of the mandible could lead to a lingual perforation, which is going to be very, very hard to manage. And that's that fossa. So that's another reason why 3D X-rays are so, so incredibly important. Now, in the maxilla, we look for softer bone. We have the vessels. The maxillary sinus is the number one thing that we actually are worried about in that area. So I didn't realize we were getting so close to the end. But so if I had to wrap this up in a nutshell, on anatomy, when I look at a cone beam and I look at the mandible, the number one thing I'm worried about is the inferior alveolar nerve. I'm also looking at the buccal shelf to see whether it's a little bit backwards where I really can't get a good restoration, because just because you have good bone doesn't mean it's a good place to put an implant. And sometimes you have, this has been the kind of stereotypical nightmare of sending out to oral surgeons, even though I think oral surgeons are awesome, is that they look where the bone is. They put it in the good bone. And then it's up to us to restore the case in that condition. We can look at it as, where do we want the crown to be? Do we have good bone to get a crown in that place? And in the mandible, a lot of times you'll have good bone, but the buccal shelf will really dive you off to the lingual, and you won't be able to really get a good restoration. A lot of times in the maxilla, particularly in the anterior, it's the opposite. The angle will push you towards the facial, and you will not be able to get a great restoration on it because you're so facial. And if I had to say some of the rules that I've really, really learned to live by, is that anterior crowns, the facial, being placed too far facial is a death sentence. So the worst cases I've ever had to manage that usually came to me because of complications is that an implant in the anterior maxilla was placed too far facially, leading to almost no good outcome for a restoration. And then you have some cases in the, the mandible or anywhere that shallow implants turned out to be really problematic, and more buccally or facially implants turn out to be the ones with the biggest problems. So if you're going to favor anything, favor the lingual, favor the palatal, because those are going to be much easier to compensate for that displacement than other areas are. So I thank everybody. I thank Biotech for having me tonight. And I know I know I ran through a ton of information with you. A lot of those in specific parameters that are like board parameters. I'm happy to send those to anybody that would like them, but I'm glad that you guys, everybody stuck around to listen to me. Thank you. Okay. All right. Well, again, I think this is my first webinar, so I'm not exactly sure. Okay. So I got the question answers now. Okay, so I had a question that, is the conical connection with the implant body related to the emergence profile? Or is the emergence profile more in relation to the shape of the implant crown? So that's a great question. When it comes to the conical connection, the conical connection is not so much important when it comes to emergence profile. Any connection is going to give you a particular emergence profile. The conical connection is going to be more ideal when it comes to wicking properties. However, the emergence profile is more related to the platform width. and I probably didn't go into enough detail with that, but it's a fairly simple formula that you can go with. If you have a restorative space, let's say you're restoring a premolar or a molar, and you know your restorative space. Let's say it's 9 millimeters mesial-distally. You know that you want 1.5 to 2 millimeters on both sides for your emergence. So you take that, so you say 3 to 4 millimeters off each side for emergence, and you back that off of your restorative space. So 4 millimeters off of 9. So your ideal implant is going to be a 5 to 6 millimeter wide implant. So maybe a four, a lot of, everybody has their different widths. So let's say you did a 5.4 millimeter implant, you're probably going to be pretty good on emergence, as long as you center that between the two contact points. And another thing to consider is that the platform is not always the width of the implant itself. So if you need to make sure to just be very familiar with the implant system that you use. And I do like the Biotech system because they're very clear on what the platform height is versus the threading. And if you place an implant with a particular platform height, you can predict your emergence profile. Okay, next is the meaning and advantages of the Morse taper implant design. Okay, so I'll go back to the advantages of the Morse taper implant. And again, I'm not a researcher. I don't, do these long-term studies. I can only tell you what I read and the trends are. But the trends have gone away from flat-on-flat connection. They have moved to a Morse taper system. And the reason is because they were seeing a lot of crestal bone loss around the platform. And they're seeing a lot, from what I understand, they're seeing a lot less of that if you move to a taper system. For one, it prevents a lot of screw loosening because the Morse taper system retains the abutment based on that Morse taper system rather than the strength and the torque value of the screw itself. A lot of times, once you get a Morse taper in, the screw doesn't even really matter anymore because the Morse taper is what's actually holding that abutment in place. And not only is it retentive for the crown, you get less screw loosening, but you don't get what was the problem with the flat-on-flat connection, and that was that from what I remember, the research said that when you chew left and right and you're flexing and you're going into lateral excursives, that flat-on-flat connection opens up a tiny bit and it wicks fluid in. They call it the hydrodynamic effect. It wicks fluid in, and then when you squeezes, it squirts that fluid back out into the crestal area. So hydrodynamic just meaning water movement. So that fluid goes in, it squirts out when you bite down, and that consistent pulling water in, pushing it out has led to bone loss around flat-on-flat connections. And I can't stand by that by my own research, but that was what was the consensus on that. Okay, next question was, what are the indications for immediate implant after extraction? Okay, so this is something I think about many times a week. So if I am considering, am I going to place my implant after the extraction? It's going to be based on, can I get an implant at the correct depth? Do I have enough buccal plate? For one, I look at the buccal plate. Can I put it below the buccal plate and still not have an extremely high restoration? If so, then that's the first thing that I say, okay, I'm good there. And if I have a really low buccal plate, though, let's say I have like a 4 millimeter buccal dehiscence, I know there's nothing I'm going to do that implant's going to work. And believe me, I learned that the hard way, and you don't want to learn that the hard way, because I put implants in that I thought had everything going for it except the buccal plate was low. And I thought I would just graft around it. It'll all grow in. And For the most part, they did not. And I live by the buccal plate rule now. Also, if there's a lot of infection, that doesn't really bother me. Infection and granulation tissue really don't bother me as it used to when I first started doing this. I can clear out the infection with antibiotics. I can granulate it out. I can curette it all out. I can graft around. I can use biologics. But I almost live and die by, can I put the implant at the proper depth that I want? Or do I have to go 4 millimeters lower than I want? If that is the case, then I'm going to put one in. But if I have a bad buccal plate, I'm probably going to graft. Okay. Next one. Okay. I know we're at 8 o'clock, but is it okay to place an immediate implant after extracting an abscessed tooth? I can tell you, yes, absolutely yes. Like I said, I'm putting in implants and abscess tooth probably 95% of the time. I almost never have to graft abscess tooth. And we have great results from that because we treated with antibiotic for at least 10 to 14 days. And it is wildly successful. We also use PRF technology, which we didn't get into today, but I don't believe that really translates to anything about the abscesses. So I say absolutely yes. For that question, we absolutely do. I don't really even worry about abscesses unless they are just really, really massive. And let's see what we got. A screw access hole for cement retained. Okay, so if you're trying to analyze a screw access hole for cement retained, it's it's not nearly as precise. You don't really have to worry about that nearly as much. It's only in the anterior. If you really want a screw retained, that's the harder thing. If you want a cement retained, you kind of have a free for all unless you are, more than like a 15 to 20% angulation on your implant. I got a question about ABOI. Anybody that wants to know anything more about becoming board certified with ABOI, feel free to contact me with that. That's become exceptionally harder in the last few years as they've moved more towards educational facilities providing the credentials that allow you to get diplomate status, but I'll help in any way that I can. And like Francis, you question, if anybody wants any guidelines shown on the slides, by all means text me because I get it. Those were the things that I wanted to know that I never even really knew until I started studying for board certification that can be really helpful. And I'll email those to anybody that would like it. And that's the last question.